If we are talking about, September 2016, it clearly means that within clinical trials and also outside of clinical trials, mutation detection for TP53 should be performed by a standardized next-generation sequencing technology that is sensitive enough to detect mutations down to a level of 1 to 5%. In terms of where should we be with the next rounds of clinical trials, I firmly believe that the sequencing testing should, at the very minimum, include other strong predictors of lack of response to chemoimmunotherapy, such as some HD1, RPS15, EGR2 mutation detection. I also think that all patients should be screened for the immunoglobulin gene rearrangements, so that we can identify the small subset of patients with hypermutated immunoglobulin gene rearrangements who respond really well to chemoimmunotherapy. And then thinking about how we can actually make best use of the money spent, having an unbiased approach that accompanies clinical trials, such as whole genome sequencing, will allow us to gather and to collect all the data that we might potentially need to make sense out of the responses that we will see subsequently from clinical trials. So I think within clinical trials, and this is the approach the UK is now pursuing, within clinical trials we would like to sequence all our patients. And so the Genomics England program in the UK is basically focusing, in the hematological program, is focusing on sequencing patients within clinical trials. So all CLL patients going into the current FLAIR study, which randomizes FCR versus Ibrutinib and Rituximab, and then we'll open a third arm, probably Ibrutinib venetoclax. All those patients will have whole genome sequencing done.